My talk is going to be mainly focused on what is that CyberKnife and stereotactic radiosurgery is doing to our everyday real life. I mean, stereotactic radiosurgery is probably one of the main tools that keeps us out of the operating room, these days with a lot less complications.
These beams intersect at points within the tumor, exposing it to a high dose of radiation, while tissue and organs in the path of an individual beam receive very little radiation. How does the CyberKnife differ from radiation therapy? Unlike conventional radiation therapy, which delivers low-dose radiation in 30 to 45 treatments, CyberKnife radiosurgery delivers high-dose radiation in 1 to 5 treatments, vastly reducing treatment time and allowing minimal interruptions to the patient's daily life.
The accuracy of CyberKnife is about 1.5 millimeter. It's very comparable to other stereotactic radiosurgery procedures. The CyberKnife is probably really an evolution in the stereotactic radiosurgery. It's becoming more and more available and indicated. We can treat multiple organs. This is the machine. So the indications for CyberKnife, obviously intracranial lesions, anything in the head. Metastatic brain tumors, probably the most common indication, primary brain tumors, head and neck pathologies, spine pathologies, which is very, very useful these days, lung, liver, pancreas, kidney, and everything. We always talk about patients' quality of life, patients' improvement of survival, but how about nobody cares about neurosurgeons and surgeons themselves. How about our quality of life? Our quality of life really has significantly improved. I think we live longer now. Neurosurgeons live longer now with CyberKnife, only because we don't have that stress in the operating room. We don't have to go after every single cells of tumors that is sometimes risky and dangerous for a patient. So now I have this feeling of, okay, back off. That's enough. You did what you need to do, and we have Dr. Burns and Dr. Zinkin to zap the residual tumor with CyberKnife afterwards. And patients, they go home after big craniotomy surgery, post-op day 1, post-op day 2. So patients, they get a combination of surgery and radiosurgery and stereotactic radiosurgery, partial tumor resection, and trying to avoid the deep part of the tumor. Again, as you see, very small craniotomy. We don't need to take half of the skull out anymore these days. So small opening on the brain, just going after the part of the brain that is causing pressure and symptoms, and the rest will be left alone for radiosurgery. By the way, this patient is still alive and she's going for a second dose CyberKnife radiosurgery. Another thing is that we can discuss all this with the patient and the family ahead of time. We can tell them, I'm not going to go after all the tumors. I'm not going to make your mother or your wife paralyzed or in vegetable state after the surgery. I'm going to decompress the brain, allow the hydrocephalus to get better, have pathology diagnosis, and decompress and leave a portion of the tumor on purpose for stereotactic radiosurgery afterwards, because that will give her a lot better quality of life. Stereotactic radiosurgery, CyberKnife, can be also used for benign intracranial pathology. Acoustic neuromas, they get a stereotactic radio, they get CyberKnife, and the tumor is controlled. Very comparable results and outcomes compared to surgery, maybe even better with less complication. Patients go home same day. Meningiomas, they can be zapped with CyberKnife radiosurgery. Microvascular compression syndromes, another totally new approach to brain pathology and all this what we call functional era. It's also using stereotactic radiosurgery for problems such as Parkinson's disease. We have deep brain stimulation, but we have also lesioning with stereotactic focused radiosurgery. So really, I think CyberKnife is probably #1 modality for stereotactic radiosurgery now out there. It's fantastic.